There will be time to answer questions after the presentation. And Amy Day will now tell you how your questions will be answered through the chat function. Amy?
So good evening, everyone. It's good to see all of you. I'm kind of, Scarlett was going to tech for this, and she's taking a break for her birthday. So now I get to sit in and listen to this. So I'm excited. Let me go ahead. So we are going to stay muted just like we do for Sunday services. And then if questions come up as things are being presented that you want to share, you can direct them to me in the chat and we can share them later. Or you can just kind of save it and then we'll have time to raise hands and do some out loud Q&A at the end. So without further ado, I will go ahead and hand it over to Patty Harvey. Thanks, Patty.
Okay. I say greetings to everybody. Thank you, all you Universalist Unitarians, for having us this evening. Corinne and I, with our group, Healthcare for All and Physicians for a National Health Program, have basically one goal, and that's educating the public about a single payer system and what that would mean and how it would save money and save lives for everyone in this country. So we know one thing for sure. I'm going to share my screen here. One thing for sure, it's not easy to change the status quo, right? Huge forces are out there and they are ready to stop us at every turn. The path to success is through an informed public that is inoculated, which is a good word to use these days, right? Against the misinformation that health insurance companies, corporate interests use to frighten and control the public. This is what they've done for decades. They don't like to see this growing public demand to do what? Simply change the way, this is what we're talking about, simply change the way we pay for healthcare and make it available to everyone. So how do we get to that kind of an informed public, quote unquote, herd immunity against these attacks? Just like this hiker on the screen, you see a lot of challenges and barriers between where he is now and the mountain in the distance. It all depends on us to make that journey and cross that great divide. So Corinne and I are calling that mountain in the distance a single payer healthcare system and what that would look like. We want to describe where we are now, and where we want to be and how to get there. We don't want to get all boring and academic, but rather address the issues that we all face as individuals and as a society. We'll each take about 15 minutes, reserve time for Q&A. First off, I want to tell you a little personal story, one that sparked my interest in changing our healthcare system. Uh-oh. There. Now, if this isn't the cutest young man you've ever seen in your life, you better check with your internet provider because you probably have some problem. This is my son, and I'm showing you his picture as a kind of spoiler alert so that you'll know that the story I'm about to tell you has a happy ending and he grew up to be a happy, healthy guy. So when he was a little kid, we bought private health insurance and it was pretty affordable and it was okay. But as the years went by, it got more and more expensive. Premiums went up, the deductibles went skyrocketing. And we really tried to avoid all medical costs if possible, right? Like you do. So when he's about 20, which is like 26 years ago, he goes off to Sweden on junior year abroad. And of course, in those days, no cell phone, no internet, and that's a half a world away. And so if you've ever been in that position as a parent, you know it's kind of scary. So several months go by and we get a phone call and he goes, "Mom, I just got out of the hospital." Oh my God, what happened? And he says, "Well, I got really sick and I felt worse and worse and I didn't want to do anything or call anyone, but then I had to go to the hospital. I was so worried about what it would cost." Gosh, guess why he felt that way? And I said, "Well, first question is, what happened?" He said, "Well, I went in there and I had an emergency appendectomy. Oh my God. So the first question, of course, is, how are you? Are you okay? And he says, yes, I'm fine. Next obvious question, how much did it cost? Answer, nada, zip, zero, nothing. What a shocker. Here's this guy. He comes to this country. He needs an appendectomy. They give it to him. He's 2 days in the hospital. It costs nothing. What's up? This is a country, my gosh, they must think that healthcare is a human right. Well, why can't we have something like that? It got me going, and I've been going ever since. So, oops, now I have to do it like that. Uh-oh. I'm having a little problem. I'm going to stop share and go back in. Darn it. Oh, shoot. It's doing it. Oh, I cannot believe this is happening.
Patty, you're not in the actual slideshow. You did see that.
Oh, I know.
have-
I know what happened. Sorry. I didn't start the slideshow. Okay, now we got it. So here goes a brief primer on single payer and how it's different from what we have today. Let's start by looking at what we want. It's pretty simple. We want to see the doctor, we want our prescription medicine, and we want to go to the hospital if we need to, and we don't want to stay awake at night worrying about, guess what? Money. In between us and all those services is the money to pay for it. How does that money get managed today? It's managed by a lot of different organizations or payers. The US government pays for some health care. It pays for the military, Medicare, Medicaid.
Patty,
What?
your slides, is everyone seeing slides? No.
Okay, hang on. Sorry.
And watch your paper rustling.
Okay. Oh. I think that I didn't. Let's see. Oh, dear. Okay. Now we'll do this, and now we'll do this. So I think it works now. So here we have the US government in the flag down at the bottom. It pays for, it's one of the payers, and states, you have the various states that also pay for their employees and for other programs. And cities pay for their employees' healthcare, universities pay for theirs, businesses pay for their workers' benefits, and then we pay premiums to health insurance companies, and they pay for medical services. There are hundreds of healthcare insurance companies who are payers. We call this a multi-payer model. There are many payers in between the patient and the services that we need in this multi-payer model. We are the only country among the industrialized democracies that do this. This is what we have today, and here's how it looks from another perspective. As you can see, getting the medical service we want is not easy. We're all caught up in this mess. So in contrast, here is single payer. In other countries, instead of all these groups collecting money with taxes, premiums, co-pays, and out-of-pocket costs, there's one single organization, usually a government agency, and it takes the money from one giant pot of taxes and pays for all the services. And in a single payer system, the medical services continue to be privately delivered just as they are today. The government doesn't own or control those services. It's that simple. You get free choice of doctors and hospitals, no narrow network, no pre-existing conditions, no denial of care. Everybody is in and nobody is out. And it's all guaranteed for life, for all medical needs, regardless of income, ethnicity, job, immigration, or marriage status. That's what's called single payer or Medicare for all. So here is a good illustration of our current healthcare system. Check out the foundation. This illustrates the incredible complexity of all these many payer systems. There's a lot of bureaucracy and waste, and that makes the whole system rickety and expensive and unwieldy. Complexity costs money. So let's talk a bit about what we're dealing with now. Here in the US, we spend twice what other countries do on healthcare with much poorer outcomes. Our statistics for life expectancy, birth, and maternal deaths compare poorly to the rest of the world. Plus, at the same time, the US Labor Department clocks the rise in healthcare costs since 1978 at 601%, 6 times as high. Some 90 million people in the US are either without insurance or underinsured. That's how we were when I was talking about our kids growing up. We were underinsured. You pay your premiums, you try to meet your deductibles, and then you don't have anything left over to go to the doctor. There are some 22 million of us who have lost health insurance due to COVID, and the result is medical bankruptcy, homelessness, and tens of thousands of untimely deaths, very preventable deaths, due to the lack of access to healthcare. This is the result of the patchwork crumbling healthcare infrastructure in this lovely photo. You're probably asking yourself, single payer sounds great, but how do we pay for it? Mostly it has to do with waste. The biggest waste comes from the for-profit health insurance and pharmaceutical companies. And I just have to add, if you're a TV watcher, you may have noticed, well, there's always been a lot of medical ads, pharmaceutical ads, but have you noticed the increase in ads for various health insurance plans? Where do they get these millions and millions of dollars to support these incredible advertising? Hey, they're using our money to propagandize us. None of those wasteful payouts, overhead profit, et cetera, contribute anything to actual care. What value do they add? Health insurance corporations are nothing but middlemen in business to make money for themselves and their shareholders, not to provide care. That's just not their job. Their narrow networks, rules, requirements, and restrictions attest to that. The less they pay you, the more they make for themselves. It's just how business goes. Getting rid of these middlemen would save an estimated $450 billion a year in this country. So on to, whoops. Oh, okay. Anyway, this sort of repeats what I was just saying, how wasteful our system is. There's 90 million Americans without health insurance or underinsured, and payouts don't contribute to care. And then we go on to this lovely slide, which was created by Dr. William Zhao, who is a really smart guy. He was responsible for the healthcare system in Taiwan, which is very, very effective, and they've done really well, especially during COVID. He put this slide together to show the savings that we could expect in California if we established these various reforms and what they would stand for. There's negotiating prices. California is the 5th largest economy in the world, and it is in an excellent bargaining position to negotiate drug and medical supply prices. Single payer is would offer one plan and one way to make claims, and it would reduce the redundancy and the complication of all those many payers. It would also, by establishing consolidating claim records, it would reduce abuse and fraud because it would be transparent. Unlike health insurance companies, if you've ever tried to find out anything from your health insurance company, you see how non-transparent they are. And of course, sharing a uniform electronic record would be a real boon. Every doctor, every hospital would have access to your entire medical record, and there would be no futzing around and updating constantly. So here we have the obvious solution is taking out those for-profit middlemen and establishing a single payer model, which would manage the money that comes between what we want and what we get, the services we need to get. Our taxes would simply be paid to the government, and the government would pay the bills. And then, of course, there's that word, taxes. I don't know if you've heard about the polls that have been bandied about where they ask people if they would like a federally sponsored payment for healthcare. And people say, yeah, sounds great. And they say, well, would you like it if your taxes went up? And they go, oh, not so much, not so much. But they don't ask the third question, which is, what if the taxes you had to pay were much less than what you're paying now for premiums, deductibles, co-pays, doctor bills, hospital bills? And in fact, that's the case. We already have, with our federal, state, and local taxes, we already pay 60 to 70% of what we would need to finance a single payer system. We would have probably some small additional progressive tax to be added to make up the rest, but there's lots of ways to get that money. We can talk about that later, but it's really crucial to understand the tax that an average family of four, and this is from Bernie Sanders' report, and he talks about with the single payer bill he has. An average family of four earning about $60,000 would be around 75% less. What they would pay in that tax would be 75% less under single payer than most of us pay now in terms of doctor and hospital bills, premiums, deductibles, and copays. These endlessly rising costs that we now have to pay is in itself a major tax. So what that means is for every resident under a single payer system, no more premiums, fees, doctor, hospital bills, no out-of-pocket costs at all. The government would negotiate pharmaceutical fees to be similar to those in other countries. The single payer system would consolidate services into one streamlined, efficient process. That streamlining, coupled with the elimination of costly and interfering middlemen, would inevitably save money and save lives. So to simplify further what we know what Medicare is today, right? We're calling for improving it, namely adding important services like vision, dental, hearing, long-term care, and lots of other stuff. And don't forget the gap that now must be filled by private insurance to pay that supplement. And that can cost 3 times what you're paying for the Medicare itself, the 80% that Medicare pays. And for the record, what my husband and I now pay for Medicare plus a supplement is almost what we used to pay for Blue Cross back in the old days. But now we have no networks, no premiums, deductibles, or copays, and free choice of doctors. But on the other hand, still, there's the drawbacks. No vision, dental, hearing, what old people need. And if you have to be hospitalized, that even with Medicare, that can get very expensive and complicated. We also got to pay for that pesky supplement. We need something better and simpler. Bottom line, while people sicken and die needlessly, and while our costs continue to rise, the real question is not, can we afford to have a single payer? But rather, how can we afford not to? So I would like to turn this over to Corinne. And she has some important additional information and relevant remarks from a physician's point of view and experience.
Thank you, Patty. I have a story as well. I was in medical school and I was diagnosed with a cancer. And I remember when my doctor came in to sit with me in the hospital, because everyone just thought it was a benign cyst. And she sat with me and she said, "You have cancer." And the first thought that came through my head was, how am I going to afford this? It wasn't, oh my God, I might die, whatever. It was, how am I going to afford this? And as a physician, I've heard that refrain over and over again. And I've also seen patients avoid or postpone medical care, and their condition got worse. I had one patient that I did a colon cancer screening on, and she was 63, and it looked like she definitely had a growth in her colon that needed a special needed surgery and treatment. And I begged her to go see a surgeon. And she said, no, I have no insurance and I'm going to wait till I get Medicare. 2 years later, she finally does see a surgeon. And 3 years later, she dies because she waited. And the cancer doesn't care what kind of insurance you have. It doesn't care that you have to wait. It just keeps growing. So as a result of my own experience and working as a physician, I joined Physicians for a National Health Program in 1989, and I've been working on this issue since then. I'm sort of single-minded about it, and I'll tell you, you'll see as I talk why. I'm going to divide the chronology of single payer in 3 phases: pre-COVID, what we had during COVID, and what we can do post-COVID. So let's start with pre-COVID. I want to emphasize, as much as our healthcare administration and system is fragmented and dysfunctional and expensive, we have some of the most amazing technology in the world. People come from all over the world to get treated here. If we have exotic, esoteric diseases, this is the place to come to try to get treated. But it's not accessible to everyone. It's accessible to people with money or good insurance. And that's what we'd like to change. Our current system is overpriced, it's inefficient, and it's inequitable. It's the most expensive in the world, and yet we have the worst life expectancy compared to other OECD countries. We have the highest maternal mortality, we have the highest infant mortality, and there's no excuse in this country that is one of the richest in the world. How did we get here? Well, our history of providing medical universal coverage is spotted. It started at least with Teddy Roosevelt, if not before. When Truman, but it didn't get through. And then Truman came and said, we need to provide a universal health care system. And I'm embarrassed to say that the AMA played a big role in preventing that from happening. John Kennedy tried to, Ted Kennedy tried to. And every time the corporations, the healthcare corporations that are making a lot of money in our current system, promulgated fear and anxiety and helped prevent the system from happening. So what happened during World War II is that companies, because so many people were fighting the war, companies were not allowed to increase wages to attract the workers to come for their companies in the United States. So instead they offered healthcare benefits. And since that time, our healthcare is tied to our employment. Well, we've all learned what happened with COVID. You know, you separate the employment from healthcare and then you have many, many more people uninsured. So what do we have now? We have a lot of waste. And this is a very interesting statistic. In 2017, the US spent $817 billion just on healthcare administration. Take a guess what our entire military budget was in 2017. It was $500 billion. So in other words, our healthcare administration, just the administration of our healthcare system, costs more than our entire military budget. And that healthcare administration is a quarter of the $3.5 trillion that we actually spend on healthcare in this country, which is about 18% of our GDP. Even with this high expense, as Patty mentioned, we have 12 to 14% uninsured people and another 70 million who are underinsured. We have people who become bankrupt because of medical bills. You go to another country, they don't even have word for medical bankruptcy. But in this country, it is the most common cause of bankruptcy. We have premiums that keep increasing. And remember, as Patty said, premiums are actually taxes to private corporations. We need to look at them as taxes. But instead of going for the common good, they go to private corporations for profit. And the taxes at this point, as if we look at them as taxes, these premiums, they're regressive. They're not progressive. So a secretary working in a medical, in any company who makes maybe 25 to 40,000 a year has to pay the same premiums as the CEO who makes $100,000, $200,000, $300,000. So if we switch to paying for the rest of healthcare with taxes, it will be progressive. It will be based on our income. And interestingly enough, 66 to 70% of our taxes currently are currently our taxes are paying for 66 to 70% of healthcare in this country already. And a lot of people don't know that because it's not, oh, I'm sorry, I'm shaking my table. Sorry about that. People are not aware of that because our system is not transparent. Our taxes pay for Medicare, Medicaid, it pays for children, it pays for military, it pays for the subsidies for the ACA, it pays for healthcare for our Congress people and for federal, city, county employees. So we're already paying a huge section. So even if we switched over to a system like single payer, we'd only really have to cover an additional 30% with additional taxes. What's happening now in addition, we're having mergers. There's mergers galore. Hospitals are consolidating, insurance companies are merging. And what does that create? Even more expense. When hospitals consolidate, like St. Joe's with Providence, they actually have more clout to negotiate with insurance companies to create higher prices for the services that they give. And so if you go and get an MRI at St. Joe's, it will cost, well, many years ago, it cost about $5,000. If you go to Mad River Hospital, it costs $3,000 because Mad River Hospital is a small little rural hospital that doesn't have the clout to negotiate the prices that St. Joe's has. And now St. Joe's keeps getting bigger and bigger, so it can charge more and more. And what does it do with that money? Well, it does provide services, but it takes some of that money that extra that it makes, and then it reinvests it in bigger facilities, which some of it's needed, some of it isn't. How many MRIs do we need in Humboldt County for advertising and to repay back loans? So there's this vicious cycle of trying to make more money, not just to cover the services that are provided directly to patients, but that's what's called a global budget, but to pay for capital expenditures, and that needs to be split. And under single payer, a global budget and a single payer and a capital budget would be split. So with all of this merging, what are we getting? Higher prices, narrower networks, because insurance companies are trying, even as they merge, they're trying to save money by constricting the choice we have in terms of doctors. So a number of years ago, our local medical society executive director noted that the networks that were listed under Blue Cross Blue Shield actually had doctors who didn't live in Humboldt County anymore, doctors who had died. I mean, they get away with murder. So she went to the CMA, the California Medical Association, brought it up, and the CMA dealt with the insurance company. So now the insurance companies have to provide networks that are up to date. But instead of them doing the work, they're actually imposing it on the doctors who have to every so many months renew their contracts with Blue Cross Blue Shield and give updated information. It's always a matter of pushing the prices, pushing the money away from the big insurance companies onto the patient or the physician. What else do we have? We have a primary care shortage. We have, when I see a patient, or when I've just recently retired, but when I saw a patient, I had to think, okay, not only do I have to look at what they may have and think about what the best treatment is, I have to figure out their insurance. And it's called a wallet biopsy. Not because I want to, it adds more work, but their insurance determines what kind of treatment they may get or what kind of medicines they can qualify for. What else do we have? We have businesses that are hurting, small businesses, huge businesses. A number of years ago, and it's probably worse now, the cost of manufacturing a car in this country is $2,000 more than Germany or Japan or Italy, because they have universal coverage, but the big companies have to provide healthcare benefits. And there's this constant conflict between workers and companies in trying to to negotiate healthcare benefits when that time could be spent in improving the working conditions and wages. Small businesses, it's crushing entrepreneurial spirit, because if you're a small business and you want to provide healthcare, it takes a big chunk out of your business. If you can't provide healthcare, then workers can come and go, because they may keep looking for a job that does provide health benefits. It even affects marriages. I've had patients who got married to get on their partner's health insurance. I've had patients who got divorced so that they could qualify for Medi-Cal, because then their income went down. So its tentacles affect every part of our life. Back to the history. In 1965, we had Medicare passed. What happened with Medicare? It allowed people 65 and over relief. It took away the worry about insurance. It allowed 65 and over to be able to go to the doctor of their choice and the hospital of their choice. And as a result, the longevity of people 65 and over actually increased. It also, by the way, for some of you may not know this, it covers people with chronic medical conditions, with certain chronic medical conditions like kidney failure. So people who get on dialysis do qualify for Medicare. And what has been found is that, for instance, Black patients who tend to fare worse under our system actually do better once they get Medicare on dialysis. They live longer than the white patients on Medicare. So they actually, overall, it can improve many, many aspects of our life if we get something like single payer. So we got Medicare in 1965. In 2010, we got the Affordable Care Act, also known as Obamacare. And that has philosophically gotten the idea that more people should qualify for, more people have a right to health care. That is one of the advantages of ACA, but unfortunately, it keeps the system as it is. It keeps the complexity, the for-profit, the multiple insurance companies as it is, and our taxes help pay for those subsidies. And I don't know if any of you have had to look for insurance under the ACA. It is mind-boggling to figure out what you need and how much you're going to pay. And the less you can afford, the cheaper the insurance, the higher the deductible. So it's pretty crazy. It maintains the fragmentation. So what choice do we have under our current system? We have a choice of insurance. We don't have a choice of doctor or hospital. And what does single payer provide? Well, a unified publicly funded insurance system is what it provides. That's all it deals with, is providing insurance. And then instead of having a choice of insurance, we have a choice of doctor or hospital. And under any of the single payer pieces of legislation that are currently being promoted, it also offers dental, substance abuse, mental health, long-term care, vision, hearing, and we can afford it because all that waste will then go directly into healthcare benefits. So now we come to 1 year ago when COVID-19 arrives, and all the weaknesses that I've just talked about become even more blatant. And our fragmented healthcare system was just not ready to handle our pandemic. 27 more people lost jobs and they lost their insurance. The protective equipment was all made by private companies. Hospitals didn't have enough beds to take care of patients because under our current systems, hospitals are sort of run like hotels. And if the beds aren't being used, they shut them down. So there's no advanced planning, there's no public health to actually manage a pandemic as such as the one that we have and are hopefully slowly moving out of. And during the pandemic, hospitals actually lost money because elective procedures weren't paid for. People didn't go in. If they didn't need an emergent procedure, they didn't get it. And yet we continued to pay the premiums. So they made a lot of money. COVID-19 was very, very profitable for corporate health insurance companies, pharmaceuticals, and the CEOs. Anthem net income in 2019 was 1.1 billion in the second quarter. The equivalent second quarter in 2020 during COVID was 2.3 billion. so twice as much. United Healthcare made $3.4 billion in the first quarter of 2019 and made $6.7 billion in the same quarter. It's not, something's wrong when a pandemic is profitable for a select group of people. So what COVID-19 did was expose all the healthcare disparities in our country. And in California, 80% of the uninsured are people of color, and yet they only make up 67% of the population. Our country's wealth is based on racism. Racism is required to accumulate wealth because it keeps people apart and separates them. And it keeps people in poverty. And what's interesting is that, you know, we have these pockets of concentrated poverty in the United States. And concentrated poverty means they're ghettos. You don't have access to good health. You have more exposure to pollution. You don't have good access to transportation. And interestingly enough, it's 50% of Black people who live in areas of concentrated poverty. Only 5% of whites live in concentrated poverty. Now that's spread across, you know, you have to look across the entire country. And the dominant culture that we live under is to blame the victims. It blames people because of skin color, blames people because of obesity, it blames people because of tobacco, substance abuse, diabetes, hypertension. All of that, it is not recognized as systemic problems. They're individualized and blamed on the patient. Slowly, with COVID, we are beginning to recognize that stress and generational lack of income and no housing or poor housing and more exposure to pollution, all these social determinants of health are equally important as the biological or actual disease conditions. So we have to look at racism as a public health issue. It is a public health issue. It's actually a public health crisis, and single payer could address that. The virus does not care who gets attacked. It just is looking for bodies. And in that way, we are all equal. So I'm saying, why shouldn't everyone have equal access to healthcare? And that's what a single payer system could provide. So let's look at post-COVID. We're getting there. We can say we're getting into post-COVID era. Can we make a difference? We need single payer. I've mentioned a couple of reasons why, but I'm going to continue to give reasons. What does single payer provide? It provides freedom because it ends corporate interference. We can choose our doctor. We can choose our hospital. We don't have to choose our insurance because everyone will have the same insurance. What does single payer provide in addition? It provides equality because whether you are the president of the United States, a congressperson, a very wealthy person, or a homeless person, everyone has the exact same insurance with a great package of benefits. So that stabilizes the system because if something isn't working, you can better believe that somebody with power and authority will complain and make that system work. It's also been shown that when everyone is under one system, it's very hard to undo, which is why, I have to say, mostly Republicans try to undo Social Security. There's such a big outcry because everyone belongs in that system, and that gives it stability. What else does single payer provide? We have freedom, we have equality. It provides justice because it's comprehensive insurance for every American, regardless of race, gender, ethnicity, income level, and whatever else divides us. And it is affordable because we have progressive taxes. So you're going to hear a lot of opposing arguments because as the single payer system gets stronger, and believe me, over 30 years, I have seen growing public support and understanding of what single payer means and what it can do. The more money is going to be spent by the opposition to promote fear and anxiety about a change, which they see as very drastic. And it is very drastic for the corporations and the pharmaceuticals, but basically the transition to single payer for the majority of people in the United States is going to be very simple. Medicare, which passed in 1965, took less than a year to implement. And boom, all people over 65 had Medicare. It was not such a big deal. So what do we need? We need education, like Patty said. And I love this quote from Henry V, by Shakespeare, he says, all things are ready if our minds be so. Another way to say it by Louis Pasteur is chance comes to the prepared mind. So when we educate ourselves, when we advocate for single payer, as people hear about it, they understand it, and it makes so much sense that eventually more and more people will support it and see that it will only help all of us and not hurt us. Biden, there was a question about what Biden is promoting. Biden is opposed to single payer. Unfortunately, he is a corporatist. He wants to expand the ACA subsidies. But in the American Rescue Plan that just got passed, that we all read about, it includes $34 billion to expand the Affordable Care Act. But remember, all that does is subsidize the private insurance companies with our taxes. So wouldn't that be better to pay for actual healthcare benefits rather than insurance premiums? Another idea that's was bandied about by all the Democratic presidential candidates on the Democratic side, except for Elizabeth Warren and Bernie Sanders, who both supported single payer, is a public option. And we heard it in many different forms. Medicare for all for those who want it. Medicare America. They plagiarized the idea of Medicare and then added a little extra to cover what really is a public option. And what is a public option? Public option, we don't even know because there's so many definitions, but basically it offers an extra layer of bureaucracy for people who don't have insurance or cannot afford certain insurance to buy into another form of insurance that could be managed by the government. It could be managed by Medicare, but it could also be managed by an insurance company. It adds a layer of complexity, another layer of bureaucracy, and it adds expense. Another option that's being offered by the opposition is it's not the opposition. It's offered by people who mean well and want to cover more people with insurance. And one of those is expanding Medicaid, which in this state is called Medi-Cal. And that's good because more people will be covered who couldn't afford or who fall in the poverty line. But it does establish a two-tier system, because if you try to find a doctor in this county, Open Door does take in Medi-Cal. Kaiser, who some of you may know, we don't have Kaiser up here, but Kaiser says, oh, we take Medi-Cal, but they only take 3 to 4% of their entire population will be covered by Medi-Cal. They don't want Medi-Cal because Medi-Cal pays less. And when somebody has Medi-Cal, as a doctor once said, it's like a big M across your forehead. And it does affect who you can see and what medications you can get and what kind of care you're going to get. It's a good insurance, actually, but it's limited as to who will provide it. So let me synopsize. Why is single payer good? It's a labor issue. Healthcare costs increase every year for workers while our wages remain stagnant. It's a social justice issue. People of color, women, LGBTQ, immigrants, disabled people will all be covered under the same insurance system, and they will receive the care that they need. It's part of a social justice issue because health justice is only one arm of the social justice issue in this country. And it's an important arm. And that's why one of the reasons I'm so involved in it, because it will help level the playing field. And even in terms of racism, will it get rid of racism? No, but it will level the playing field because everyone will have equal access. Did slavery eliminate racism? No. Was that a reason not to support slavery? No, of course we wanted to end slavery. We still are dealing with racism, but it was a big step towards working towards hopefully the idea of equality for everyone. It's an economic issue because taxpayers and businesses currently are wasting millions, billions of dollars annually to subsidize pharmaceuticals and health insurance corporations, and they're making those record profits. So the whole idea of single payer is people over profits, everybody in, nobody out. We don't pay for a fire truck to put out a fire, but we pay for an ambulance. Let's make healthcare as easy as a library card to get a book. Let's make healthcare as easy to get healthcare. How do we get there? Well, there's many ways for all of you if you're interested, if you get bitten by the single payer issue and want to participate. Right now, the California Nurses Association has helped write a bill called AB 1400, which was introduced by Ash Kalra. He is a state assembly person out of San Jose, and he introduced AB 1400 on February 19th. In 30 days, it has to go to the health committee. Now, this is where all of you have a superpower, and I hope you use it. Why? Because who heads the health committee? Jim Wood. Jim Wood is our assembly person. Jim Wood never says he's opposed to single payer, but he does everything to prevent it from being implemented. He's done it over many, many years. I'm not sure why. He's a dentist, but he just, I think because he gets some money from insurance companies and pharmaceuticals. So with your superpower, you can call Jim Wood and say, I am a constituent and I want, when AB 1400 comes to your committee on March 22nd, I want you to help promote it. I want you to help make it happen and not to try to prevent it from happening. So that's, politicians, they either listen to money or they listen to their constituents. And the more people who call, the more power we have. Then the CNA is also running a texting and phone campaign, which I will put in the chat, how you can sign up. And apparently, I haven't started yet, but it's very easy. And you get to call people and inform them. You don't even have to know that much about single payer, but let me tell you, after Patty and I harangued you, you will know more than 90% of the population. So you can also volunteer for this texting and phone campaign. There's a petition for Newsom that you can all you have to do is go to petition.healthcare. He's been a single payer promoter, but he has a lot on his plate, and he also is a politician, so he's backed away a little. But we want him to request a waiver from the federal government to transfer funds from our taxes back to California, so California can implement something like AB 1400, a state single payer system. We also are going to start a resolution campaign. We want to go to all the city councils, or as many as we can, to help to see if they will sign on to resolutions that support single payer and specifically AB 1400. It's a lot of work. So if anybody knows people on various city councils, please let us know. We'll put our email so you can contact us. And look out on the national level, because there's parallel courses. There's the state and there's also national. There's a single payer bill that in the past congressional session was called 1384 in the House of Representatives, and it is being reintroduced by Congresswoman Jayapal. We don't know the number, but apparently next Wednesday it will be reintroduced. And we need to organize to get Huffman, who has signed on to single payer, but is not an active proponent of single payer. Basically, he believes in incremental reform, and incremental reform is a death call for single payer because it stops the momentum dead in its tracks. And then consider joining Healthcare for All and or Physicians for a National Health Program. And if anybody wants to know what's going on with Cloney's and Redwood Memorial, I can tell you what the commonality is between the two. It's obviously our current system.